Okay, so welcome to Defend 3.0. Today we have another excellent guest speaker who will speak about how food and physical activity policies impact our health. I would say he's definitely an expert locally as well as nationally. And thanks for all of our defenders who have been participating. I think Defend series has reached its 1 year anniversary. So we're more than halfway through Defend 3. So congratulations. And thank you for keeping loyal to our project. We really appreciate it. It wouldn't be possible without you. And I know many of you have received emails. If you hadn't completed the midway survey, you have until Sunday to complete it. Emma will send another reminder today. We have about, I think, 39 out of 99 initial respondents. So here is the link. The link is on the Defend website. And if we can appeal to your emotions, all this data will be used for Emma's master's thesis. So answering those surveys is really important. And then again, we would thank everyone who does attend our personalized coaching sessions. We have 3 excellent personalized coaches. Danielle, who talks about behavior change. So those of you who are over halfway and still struggling with your SMART goals, Danielle is excellent. Our nutrition coaching with our registered dietitian nutritionist, Jamie McDermott. And our physical activity and exercise coach, Bryce Daniels. They are happy to answer your questions. They're full of excellent tips and tricks, especially as we're approaching summer. We in the beginning, you were interested in how to get working through the pandemic, social distancing in winter time, but now that we're all going to be coming back to work, if we're not already there, and approaching summer, maybe your ideas have changed or your needs have changed. I totally forgot to update this slide. This is the wrong challenge. This is from last week. Emma, what was this week's challenge again? Because we're
this week's challenge is, let me pull it up. Oh, it's to make a fiber swap. So you want to swap some source in your diet for a higher source of fiber. So instead of white rice, maybe use brown rice or a whole wheat bread instead of white bread. And then you can post on the Facebook, comment on the Facebook challenge post, or send an email to the Defend email to complete it.
And I'll make sure we update this slide before it gets posted on the Defend website. And I also want to challenge you, think about the US dietary guidelines for Americans for fiber. I think it's around 25 grams for women and 30 to 35 grams for men. Track your food for one day, see if you're meeting these fiber needs. And then I also challenge you during the fiber swap to try to meet that for one day and see how you feel. Again, go to our YouTube channel for demonstrations and our website for fast facts. As we come to a close over the next 6 or 7 weeks, if there's information that you'd like via YouTube or fast facts, let us know and we'll make sure we produce that information for you. And you'll find recipes full of fiber on YouTube today and how to active transport. So it's my pleasure to introduce today's guest speaker, Dr. Chris Long. I've known Dr. Long now for several years. I think Dr. Long and Dr. Howie and I all met at the same time through a shared research experience. He's an assistant professor of medicine and the senior director of research and evaluation at UAMS Northwest. And Chris, I didn't choose your faculty page because it was too blurry. But I'm going to stop sharing and let you go ahead and share, and then I'll read your introduction while you share your screen.
Awesome. Let's see if I can make this work.
Hold on a sec. Oh, come on. 1 second. Yeah, I see it. So okay, so first, so Dr. Long, like I said, is an assistant professor of medicine at UAMS Northwest. He's a research psychologist who studies interventions to improve the nutritional health and well-being of people who are food insecure and at high risk for chronic disease like diabetes and hypertension. He's based in their Fayetteville campus, and he's really modest, but he's had much success over these last few years. His research is funded by the National Institute of Health, U.S. Department of Agriculture, and the U.S. Centers for Disease Control and Prevention. He's an excellent colleague and collaborator, and put your email on my slide, Chris, because since we're targeting extension agents and people within Arkansas, I thought you might be the go-to person for some of the questions they have.
No,
So
thank you.
after that, I'll mute myself and take it away.
Awesome. So I'm really excited to be here to chat with y'all this afternoon. Aaron and Jamie are awesome. Like I'm always excited to collaborate with them on anything. Like Jamie said, I'm over at the UAMS Northwest campus in Fayetteville, and I'm always excited when I get to interact with folks from the University of Arkansas Fayetteville and in the ag department as well. I also do some things with extension, so I'm excited to be able to chat today about some of that work as well. So the topic that I was asked to talk about is, how do food and physical activity policies affect our health? And let me see if I can get this to work. Good. And so the way I thought that would be easiest to sort of jump into this topic is to figure out, why in the world did Jamie and Aaron ask me to come talk to y'all about health policy? Because I know some of the folks on this call do a lot of health policy work in their everyday life, in their job, and so do I, but I do it in a pretty specific kind of way. So my job, I'm a researcher. That's what I do 24 hours a day, 7 days a week, it feels like. And our work at UAMS Northwest in community health and research involves a pretty specific set of steps. And it's like what it says up there on the screen. I start every project with talking to different community groups, talking to different populations about what challenges and goals they have for their health. What are some issues? What are some health disparities? What are some things that would make their communities healthier? And then we talk to them also about, what special resources does your community have? Does your group have? What barriers does your group or your community face that affect your ability to achieve those goals or sort of overcome those health challenges and disparities? And then we work closely with those groups to develop, and I'll use policies today as kind of a shorthand for interventions that involve changes in the sort of systems and environments that are stable and designed to sort of endure, to nudge people towards, healthier outcomes. And then once we've sort of settled on what is this intervention or what is this policy going to be, we help implement those policies, evaluate those policies, and then refine them to see if we can make them more efficient or more effective for the members of those communities. So that's kind of at a 10,000 foot level what I'm always doing as a health researcher. So as a former professor that used to teach a bunch of classes, I always like to start with like defining stuff. And so some of you, this may seem trivial or silly to start with, but I think it's important to take a step back too and say, well, what do we mean when we say policy? And so if I look up policy in a dictionary, what it says is a policy is a definite course or method of action selected from among alternatives and in light of given conditions to guide and determine present and future decisions. This is to me, it came straight out of the dictionary, but it's an amazing and pretty informative definition of a simple little word. Like the point of policies is really in the health world, I think, to guide and determine our present and future decisions, to sometimes make it simpler so that we don't even have to make some of those decisions that we sometimes find ourselves, tempted to choose maybe less healthy options or outcomes, or in a confused state where we don't always know what is the best outcome for ourselves and our health. And policies are definite, right? They're designed to be something that you can kind of put into place and then refine when you need to, but generally kind of leave them alone if they're working for everybody involved. So here's some questions, I think, that to sort of bring policies literally to your home or to your level. Or, do you let people smoke in your house? Like that's a question. It's probably less of an issue than it was 20 or 30 or 40 years ago, but that's something that we probably all have to decide on some sort of level. Like, is it okay, if your relative or your friend is a smoker, will you let them smoke in your house or in your car? You know, are you a vegan? Do you have like certain rules that you implement in your daily life about what you eat and what you don't eat? You know, when you're standing at the grocery store, do you have any sort of set idea about whether you're a family or a shopper that buys whole milk or 2% or skim milk or almond milk or none of that kind of stuff, oat milk? If you're a person who rides your bicycle, are you one of those people that always wears a bicycle helmet, or are you one of those folks that never wears a bicycle helmet? I mean, these to me are really good and simple examples of health policies that we kind of set for ourselves or for our homes. You know, that it's a little bit different. I think sometimes people, when we think of policies, we think about like the Affordable Care Act or eligibility for SNAP. But at the individual level, we set a lot of policies. And again, that definition from the previous slide, it fits. You know, if you're a vegan, or if you're a person who doesn't eat red meat but only eats fish, like that's a policy that you've set for yourself, maybe because of health, maybe because you don't like the taste of something or another. But these are all like day-to-day examples of policies that we can set for ourselves that will impact our health, which gets at this big question of why are we even talking about health policies? Like, why is that even a thing? And the reason is, I think, primarily that health policies help us see what our goals are or clarify what our goals are at lots of different levels for our health outcomes. You know, do I want to lose weight? Does Arkansas want to lose weight? Does the United States want to lose weight? Does the world want to lose weight? Well, if that's one of our goals, then one of the main ways we're going to try to achieve that is by putting into place these sort of definite decision-making heuristics that are going to help us decide, like, this is how we're going to behave moving forward to reach these goals. Like that middle point in the slide there, policies at the sort of local and national and international level often take the form of things like laws or regulations or procedures or protocols or policies or executive orders, incentives. Like those are all sorts of law and economic kinds of terms that are often interchangeable with policy when it comes to making decisions about our health. So for example, you know, I just pulled one out of the air. Like if Arkansas decides today that, you know, we want to make sure that there are fewer traumatic brain injuries in Arkansas for Arkansans because that's a problem, we might ask our legislators to pass a law that will mandate bicycle helmets on public streets. That's an evidence-based practice, right? Wear a bicycle when you or excuse me, maybe not wearing a bicycle, but wearing a helmet when you ride a bicycle is a thing that we know on average seems to prevent traumatic brain injuries. If that's one of our goals, then that's the kind of policy that we might want to propose. And when I just said there, it's evidence-based, that means that like if we do it, chances are that it will work or that it's worked in other places. So it might be likely to work here too. So I've kind of already gotten at this concept, but I think it's really important to think about is like when we say health policies, there's a whole spectrum of life, of society, in which we can introduce different policies that have been shown to make our health better, to make us live longer, or to help us manage our chronic diseases or prevent development of chronic diseases. I wanted to just remind everybody that policies can be little and simple, or they can be giant and complicated. So for example, and this is not exactly true of me, but I thought it sounded better coming in the first person. So like as an individual health policy, if I'm following, you know, Mediterranean dietary recommendations to sort of minimize my risk for cardiovascular disease, then I should have a policy where I eat fish 1 or 2 times a week, but not deep fried fish. Like if that's a policy that I put in my life, then it should, at the aggregate level, if we were all doing that, we're all going to be at less risk for cardiovascular disease over time. That's an individual personal decision that I can decide. I'm lucky enough to be able to choose every night what I want to eat for dinner, and I could choose fish a couple of times a week as a policy, as a definite course of action that helps me make a healthier decision. Like, there are also interpersonal policies, like, in theory, I wish I had this policy in my house, but we could have a policy that, like, we minimize screen time for entertainment purposes to 2 hours a day. Like, my daughters and I, we could sit around the kitchen table and decide this is what we're going to do, and we're only going to look at our phones for fun, our TVs for fun, our computers for fun, for 2 hours a day. Chances are, if we did that, we might sleep better, we might get a little bit more physical activity, like we might be at lower risk for overweight and obesity. That's an interpersonal decision that we sort of make at the household level. That's an example of a health policy that we could implement, or that we could encourage other folks to implement. At the organizational level, there's a health policy where I work at UAMS that I have free access to at least a few sessions of mental health services every year. If I'm having issues with anxiety or depression, my organization has decided as a policy that this is a service that they would like to make available to their employees in order to improve our sort of emotional well-being over time. And evidence suggests that that's a good thing, to make mental health services free and easy to access. That's an organizational policy. I'm sure y'all, those of you who work at U of A or at Extension or at the Division of Ag, like, you have policies that your organization has set out about, ways that you can be healthy. Our communities also can set policies, right? Our local school boards could say, Arkansas says you should have this many hours of recess per week, or minutes of recess per week and per day, but we're going to add extra because we in Fayetteville or Bentonville or Rogers or Greenland or wherever want to, increase the likelihood that our younger students are going to get more exercise and maybe sort of lower their risk for obesity and overweight and other chronic diseases. So that's a community level policy that we can put into place if that's what we want to do. At a national level, we have plenty of health policies that many of us don't even understand how they work. One good example is SNAP, or what people used to call food stamps, right? Like, we in the United States have decided that that's a benefit that we want to provide to food insecure families, and it's a wonderful evidence-based program to help improve people's food security and their health outcomes as well. And so that's a nice national level policy that's there with the sole purpose of, improving people's well-being and helping them to prevent and manage chronic diseases. So that seems like a little simple word like policy, but you can see it affects our lives in many, many different ways. And why do we keep putting all these policies into place? It's because they make a big difference, because they work. And why do they work? Well, they work because they sort of nudge us towards making healthy choices, or at the same time, sometimes they can minimize the appeal of unhealthy or less healthy or more risky behaviors. So, for example, in some states, there's a law that says you better wear your motorcycle helmet, or you will get pulled over by a police officer and they will make you pay money. Like, what's the point of that? Well, it's to encourage you, right, to wear a helmet. And if that's encouragement by itself, if that reminder, like our state thinks it's important that we wear a motorcycle helmet, if that's not enough to sort of motivate folks to wear a helmet, there's also this sort of punisher built into that, a sanction that says, well, if you're not going to do that, we're going to make you pay money, and hopefully that will encourage you to do this thing that we've decided as a state is an important value. Another example of sort of one of those community level policies in a lot of places is adding fluoride to your water, right? The water that comes out of your faucet in the kitchen or your refrigerator, if you get water to drink out of there, a lot of municipalities add fluoride to that because it improves the health of our teeth at the municipal level, which is, we've decided that's a good thing in a lot of places. The idea is there to nudge you to drink the water that has fluoride in it because it's super easy. It's what comes out of your faucets in your house. If you don't want to do that, that's okay, but you'll probably want to then buy expensive filters or deal with some of the inconveniences of always needing to shop for bottled water or whatever. Again, this is an example of why health policies work, is they kind of make the default in a lot of cases a healthier outcome than some of the choices that we might have to, put a lot of effort into doing ourselves. But health policies can be kind of controversial, right? When I go out to talk to different community groups, or when the Arkansas legislature has been in session, there's been a lot of discussions about health related policies this year. And a lot of it can get pretty emotional. A lot of it can be upsetting. It's not, as an employee of the state of Arkansas, there's a lot of, opinions that I may or may not get to talk about today about what I think about it. But that said, it doesn't mean that it's not something that we need to have in our minds, right? So what are some of the pros and cons of health policies? Well, the first one is, the most desirable consequence of a health policy is obviously improved health, right? It's going to help us prevent chronic disease, manage chronic disease, feel better, be emotionally better, be happier. Like those are the points. Like if a health policy is working right, then that's going to be the reason that we put that into place. The undesirable consequences, though, related to that are sometimes health policies can have unintended harms, right? Like the thing that we thought was going to improve people's access to healthcare actually made them less, engaged and willing to participate in the healthcare system. The things that we thought were going to, help people eat better actually cost a lot of money for school systems, or cost a lot of money for restaurants, and put some restaurants out of business if certain health policies perhaps. And so sometimes there are these unintended consequences of policies that are even unforeseen, sometimes consequences of policies that make them less desirable to certain constituencies. There's probably, for every policy, there's probably this trade-off between, is the cost of this policy worth the degree to which it has a positive outcome? Another usual desirable consequence of a lot of health policies is, like I just mentioned, improved access to health services, right? We do a lot of stuff to try to make people have easier access, for example, to preventative care. Like that's a big issue in the last couple of decades in the American healthcare system, is to say, like, how can we make it cheaper and easier for people to access annual doctor's appointments, to get their teeth cleaned, to get their eyes checked? How can we get people to do all of that stuff? That's a desirable consequence, but sometimes, there are sort of unintended consequences that cause people to not have as much access to health services. Sometimes people talk about, I make too much money to get that benefit because I'm sort of too wealthy for that. Or, maybe I have a certain legal status or immigration status, and this new health policy makes it where I'm scared to access it because I'm afraid of where those records go that this new policy has put into place. So sometimes we make policies and the idea is we want people to have more access to something, but the unintended consequence or the undesirable consequences for some folks, it can go the other way. All policies that are sort of implemented at a large enough level, at some point there's going to be a cost effectiveness evaluation of that policy. Like ideally, policies will save us money, and sometimes that is actual like money, like dollars, and sometimes that you can sort of see, like it costs us less every month to buy the thing that we need to buy at the household level or at the municipal level or at the national level. Sometimes it saves us money in terms of healthcare that we don't need later, right? There's a lot of preventative health policies like that, like fluoridation in the water is a good example of that. Like it doesn't necessarily save the city money that month to put fluoride in the water system, but the idea is that over time, collectively, our economy has less of a drain on people missing work to get their teeth drilled, or having these expenses that are unanticipated, that we pay a lot of money to go to the dentist to get extra services. So that's, the ideal outcome is that kind of savings. However, sometimes there are not, sometimes always just about for health policies, there is going to be a cost too. Like that most health policies are not free to implement. Sometimes those costs are easy to anticipate. If we say, we have to improve, the the quality of food that we put in school lunches for whatever reason, then like we know that sometimes that food is going to cost more than other food, even at the household level, right? Like sometimes people make decisions like, I think we need to get better air filters in our HVAC system because I have trouble with allergies. And I think that a policy of buying more expensive air filters is going to help my health over the long term. That's there's a desirable consequence, but I know that those allergy reducing air filters cost a lot more than the regular ones do. And so that's can be an undesirable consequence of a health policy. Often we develop health policies to reduce inequities and disparities, to make it easier for people to access care. But other times, we develop health policies maybe to save money that remove options that help people engage in our healthcare system in the US. So those can be, something to keep a look at when you are evaluating a policy. Like, is this thing going to sort of help everybody improve their health, or are there going to be a lot of really distinct winners and losers? And who are those winners and losers going to be, and how are they going to win and lose? Another one that sort of gets to like that personal level of health policy is, this issue of increased autonomy versus decreased autonomy. If you go back to the motorcycle helmet one, that's a real easy one for me to think about. Like, people that do not want the government to tell you to wear a motorcycle helmet. Like, that's my business. You're not supposed to take my choice away. And so they feel like the unintended, undesirable consequence of not having choice does not outweigh the potential, risk reduction of not having a traumatic brain injury if I happen to fall off of my motorcycle or whatever. And so that's a big tension at the societal level. Like, and how much do we value autonomy versus, sometimes minimizing someone's autonomy in the interest of putting into place a policy that's going to, over the long term, possibly decrease the incidence of certain diseases or health conditions. So that's a lot to think about when you're deciding, like, should I eat fish twice a week, or should my country like provide, economic benefits to people that don't have enough food to eat? Like, obviously each policy is going to have a different sort of set of calculations, but whether I'm talking to a church group about like, maybe we should think about, do you want to say we serve water instead of sugar sweetened beverages at our, at our church gatherings? Like, some version of these pros and cons will come up in people's heads when they're thinking about that sort of decision about that policy. It's a lot different, of course, if we're thinking about like some piece of legislation similar to the Affordable Care Act, where it would take us hours and hours and hours of our lives to figure that sort of out, these sort of calculations out. But at the same time, I think these things apply at all the different levels. So I wanted to close out today by just talking about a few examples of how health policies have been implemented and my team's work here in Northwest Arkansas, the community health and research team. We do a lot of stuff around nutrition. And so in one of the contexts in which I work is food pantries. And so if you've spent time studying food pantries and food insecurity, one of the things that you'll know is that folks that are food insecure are at really high risk for a lot of chronic diseases that are sensitive to nutrition, including diabetes. And so what we know is that there are a lot of folks that have diabetes and other chronic diseases that are going to be in line at the various food pantries across Northwest Arkansas. And so we worked with the food bank and with the food pantries across Northwest Arkansas with the explicit goal of what can we do to improve clients' nutritional health here in our region. And so one policy change that we've helped some agencies put into place is to think about, well, what kind of nutrition policy would you like to have as an agency? And one of the sort of common elements to those policies is thinking about their food acquisition activities. So like when you're asking people to donate food, or when you're buying food from like the food bank or from another distributor, like you might prioritize fresh produce where possible, or low sodium canned vegetables where you can afford to pick those instead of regular sodium canned vegetables. Where possible, can you ask for donations of lean proteins or purchase lean proteins when you have the choice between different proteins to acquire. Same with whole grains. Obviously economics enters into this, like some of those choices are more expensive than other choices. But on the aggregate, if these food pantries will try, where possible, to make healthier choices where they can afford it, then the long-term, outcome of that is that they're providing healthier options to folks that are at high risk for either uncontrolled chronic disease or for developing chronic disease in the first place. So that's an example of a health policy that a food pantry can put into place. Another policy context is like a free community meal program. So it's sort of like what some people call soup kitchens. There are several organizations across Northwest Arkansas, like every day you could go get a free lunch somewhere in Northwest Arkansas. And what we know, like similar to the last example, is the folks that tend to be in line at those programs are at high risk for diet sensitive chronic diseases like hypertension or high blood pressure. And so we've worked with several programs across Northwest Arkansas to think about, everybody eats too much sodium, to be honest, just on average. But these folks that are at particularly high risk, is there anything that we can do to help them consume a little less sodium on the day-to-day? And one really simple policy action that several of these programs took is they decided, rather than put a salt shaker, which is super common in the American South, to put a salt shaker in the middle of every dining table, what if we take all the salt shakers and put them over in the corner of the dining area, where people, if they want to add salt to their food, they have to get up and walk across the room and go get some salt and put it on their plate, and then go back to their table. What researchers have found is there's a lot of folks that won't bother to do that, whereas they'll reach across the table sort of instinctively and shake salt on their plate. But if you just take a simple step of moving the salt shakers to the other side of the room, a lot of people that normally would have added salt to their food won't get up to do that. And that's a pretty low cost intervention. It also preserves some autonomy, right? Because if you still want to add salt to your food, it's still in the room. You just have to go through a little bit more effort to walk across the room to get it. And then finally, the last example that I'll talk about from our work today is in school district nutrition. So like for a lot of folks, particularly kids that are food insecure, there's a lot of their calories come from what they get to eat in the school breakfast and school lunch meal programs. Arkansas's children, across levels of socioeconomic status, are at relatively high risk for overweight and obesity. So we have this sort of intersection of two circumstances. A lot of kids get a lot of their food from schools, and a lot of kids in Arkansas are at high risk for overweight and obesity. So maybe we could set a goal in collaboration with our school districts to say, what kinds of foods could we feed our students to help them eat healthier foods and maybe mitigate some of that risk. And so one of our programs has been to help school districts adopt comprehensive nutrition policies that exceed our USDA national standards for school breakfasts and lunches. So like we'll try to help them encourage lean proteins at breakfast, for example, which is not necessarily a required thing. Maybe minimize access to flavored milks, which tend to have a little bit more added sugar in there. Think about the opportunities and types of food that they sell that sort of compete with the school breakfasts and the school lunches, and are there ways for them to sell healthier options at those times? And then also, is there a way to integrate these changes into our local food systems in a way that could benefit some of our farmers and growers here, which could have a sort of knock-on economic effect outside in the larger world, outside of the walls of the school. So that's an example of a pretty big policy that has a lot of implications that, if implemented, would have a very good long-term impact on the way that our kids in Arkansas eat. So that's a very quick run through of what health policies are and sort of how they are used in the work that we do here in Northwest Arkansas. So thanks for giving me a chance to share.
Thanks, Chris. That was awesome. I always enjoy hearing. I feel like I followed your research for like the last several years as like a little fan club.
Thank you. That's super nice.
I like to hear the progress. We did have some comments, but I think it was maybe back from the beginning of your presentation about buying whatever wasn't in stock. Erin said she really just buys whatever kind of milk Dollar General has, and others try to buy Whole Foods versus processed foods.
Yeah, so that's kind of a silly example, right? Like to say like what kind of milk do you buy? But one of my longer term interests, like I'm a person who likes rules. Like I've probably a lot of y'all who are scientist people like rules and interventions and setting up systems and trying to be super efficient. And one of the places I think that health policies are at the household level are going to start to be a bigger and bigger deal is how we shop for food, right? Like before the pandemic, a lot of us used to go into stores and walk around the aisles and like put stuff in our carts. Probably the pandemic has accelerated the extent to which we buy groceries online, whether to get them picked up and dumped in our trunks or whether we ask people to bring them to our front door. I think, moving forward, those of us who work in health research, one of the next big challenges is going to be, in this world, or it's actually an opportunity rather than a challenge, I think, in this world where we're sort of shopping from our phones or from our computers, I'm not walking past the Twizzlers anymore. Like I don't have to have that impulse. Like Erin says, she buys what's in stock. Well, now I can have a grocery list where I just press a button and all that stuff is in my cart and I didn't even see all the other stuff. Like I don't have to decide if I'm going to buy the chocolate croissants because I didn't even know that they were there today. I just pressed the button. And so if we can start to encourage people like your respondent who said something about trying to buy whole foods versus processed foods, there's now going to be this mechanism where your household could actually say filter out all the stuff that I don't need to see anymore. And so that it seems kind of silly and trivial, but at the societal level, if we started to make some of those individual decisions and household decisions, we would suddenly see a vast improvement in probably our nutritional intake.
I will say, I started monitoring food waste as a pandemic project in my household, and how much money we would waste on that bag of spring mix. I think there's that meme that goes around oops, I forgot to I almost left the grocery store without buying the bag of spring mix I'll throw away next week. But so then we calculated that if we actually bought into one of these meal delivery kits, we could filter out all, like you just said, all the junk food, all the waste, and now we just get exactly what we need for that recipe. And vegetarian or Whole30 or whatever you're doing. And we found that actually, even though they're kind of expensive, it saves us money because we have 3 meals a week that we have no waste.
Mm-hmm.
So that's pretty.
That's
portioned.
Yeah, that's a perfect example of when you subscribe to a thing, you're setting up a system. And I like to, I'm not I know you can get your PhD in health policy at U of A, and that is not always the kind of policy that I guess I should acknowledge that I use the word policy to mean a lot of different things in the work that we do, right? I'm not I'm not a policy researcher per se, but I think in the context of policies and systems, what you just said is a perfect example of hey, I just signed up to Blue Apron or whatever web service that it is, and I accidentally bought into this system that comes with a whole bunch of decisions that I no longer have to make. I don't have to decide, you don't have to choose how much food to put on your husband's plate or onto your plate, or he to put on your plate or your kid's plate, because they did it for you. It's in a little bag for you, and it's correctly tied to to USDA guidelines probably on some level. and you didn't mean to make that decision. Like when I chose to subscribe to the Walmart food delivery service and make this commitment to like they're going to bring my food to my house every week, or I've paid for it anyway for them to bring it to my house. Like I didn't really think like, oh, that means I never walk by the Coca-Cola aisle anymore, and I won't choose to buy that, or I don't have to walk by the chips aisle anymore, and I can just have this list of favorites. And I think that's like some of these policy decisions are things that we make almost accidentally, and that can be scary to a whole lot of people. You know, the slide of pros and cons about autonomy, like that's a giant sort of philosophical debate that if I was a health policy researcher in the sort of formal sense, I would want to think about that a little bit more carefully. But I tend to work on, a lot of us here in Northwest Arkansas too, tend to work on the sort of household level or community level or organization level, where there's a little bit less controversy than I think than if we're designing a whole new sort of legal structure.
Yeah. You did have one question from Lisa Barnes. She wanted to, for great presentation, and where can she find your published work, and are you on any social media?
I am officially not on any social media.
But don't you, I think your team, don't you guys have social media?
Yeah, they do. Like, so there's the Office of Community Health and Research Facebook group or page. I forget the sort of technical term that it is, but UAMS Office of Community Health and Research will get you to what our office does. There's a website that I can share with Jamie that has a list of all of our publications. I'll look while we're talking and I can put it into chat. I'll actually do two things. I'll put, the easier thing is to put my own publications into chat. But thank you for your interest.
Yeah, I think, and we can do some digging too and send an email around with the link to the Facebook page. I can figure out what the exact link is, and we can share it on our Facebook page too for y'all to find.
Yeah, thank you. I'm trying to get the little chat window back, but now I can't make it happen. Oh, because I'm
Just
sharing
text
my
Bonnie.
screen.
Maybe I'll ask Bonnie. She presents next week. Our speaker next week is also on. Chris works with Chris. Maybe I can ask her to share the Facebook info.
I put the link to my publications in there, and there's like 20 years of stuff that spans a long career that's not all about health, but you can see some of the work that we do with Pacific Islanders and with food systems here in Northwest Arkansas too at that link. That's some of our published papers. But I'm also happy to chat via email too. So if anybody wants to reach out.
I'll put your email. CR Long too, right?
Correct.
You guys have easy to remember emails at UAMS. Okay, yeah. Well, thank you so much for your time. I appreciate everyone that joined us. As always, Chris, really interesting and I think really relevant to our state. And Chris usually speaks in my class every semester as well. So for those of you interested in the fall, I haven't hit him up yet, but it's coming once I know when classes, once I get myself organized. It's a great presentation. And I'm also, I think, in charge of our food science seminar, Chris, this semester. So you may also get another email at the graduate school level to present like data and things like that.
That would be awesome. I'm always happy to chat. And our team is too. Some of you I know are extension folks and in other parts of U of A. And so if you're interested in having more interaction with our UAMS researchers, we have experts from that focus on nutrition systems work like I do. We also have a lot of folks that work in maternal and child health that would be happy to chat with you and your extension groups for sure.
Yep. So thanks. And this recording will be posted on YouTube, Chris, just to let you know, you'll have a presence. But we don't tag people or anything like that. And I really appreciate your time. And we'll see you all next week. Thank you. And don't forget to eat fiber. Okay, take care. We figure out.